The focus of our presentation is how to apply concepts of relational inquiry in assessing pediatric pain. Seeing that pain is subjective, it may be hard for nurses to understand the severity of the pain or even for the physician to diagnose the cause of the pain if there are no physical signs. With that said, we as nurses can still take the time to understand them and what they're trying to explain to us, even if we don't fully understand the reasoning behind it. The quote here says, pain is difficult to define because it can have many variable characteristics and it is a subjective feeling impossible to accurately measure. This quote from Brandon Thorpe captures one of the complexities of dealing with a client's pain. It reads, "The inability to communicate in no way negates the possibility that an individual is experiencing pain and is in need of appropriate pain-relieving treatment. This is very much applicable to young children who may not have yet developed speech abilities." What is pain assessment? Pain assessment is an important component of emergency department care. Children present unique challenges to assessing pain. This quote above says, "The use of pain assessment tools appropriate to a child's age and cognitive development play a vital role in improving pain assessment documentation, prompting nurses to provide pain medication."
The next logical question is, why is pain assessment an important tool? Oligoanalgesia, underuse of analgesics in the face of valid indications as defined by Ramir et al. In children can lead to the following: exaggerated and chronic pain in subsequent procedures, pain sensitivity, weakened analgesic effects, and in children with chronic illness who are exposed to hospital settings frequently, it can lead to development of chronic pain ailments, brain abnormalities, and even antisocial behavior. Signs and symptoms of pain in children. It can be difficult for a child to accurately describe the pain they're experiencing in detail or even at all. Using drawings, symbols, and number scales can help them to express their pain and feelings. Faces expressing a range of emotions from extremely happy to extremely sad are commonly used. Children may have not yet reached the developmental stage to understand pain concepts. Pain often remains unrecognized and underestimated in pediatric populations. Infants respond to pain physiologically, resulting in increased blood pressure, tachycardia, and facial expressions that include tightly shut eyes, eyebrows low and close together, and mouths open. Older children tend to show pain through flailing of their legs and arms. They tend to resist comfort measures, or they may become physically rigid. Teens may manifest pain through withdrawal and lack of communication. Pain assessment techniques. Facial expressions are the most sensitive and specific nonverbal indicators of pain. Many pain techniques for assessing pain utilize observational methods. There are several observational techniques nurses can use when assessing pain. Some of them are behavioral scales, self-reported scales, which are more appropriate for older children, and verbal numerical rating scales, also more appropriate for older children.
Observational pain scales. The FLACC scale relies on behavioral indicators to assess pain. It stands for face, legs, activity, cry, and consolability, and is used on children aged 2 months to 7 years. The CFCS scale is the Child Facial Coding System, and it was designed to assess pain in children aged 1 to 6 years old. It focuses on 13 facial actions likely to be observed during acute pain. The PEPPS scale stands for the Pre-Verbal or the Early Verbal Pediatric Pain Scale, and it's a measurement of pain in premature infants through to toddlers of 36 months. Items were based on consultations with experienced healthcare providers, and it was conceptualized to measure the established pain response in toddlers, and it consists of 7 categories. The CHIPPS scale is the Children's and Infants Post-Operative Pain Scale. It was designed for pain assessment in newborns to 5-year-old children after having surgery or post-operative. And and it was developed using behavioral indicators of pain drawn from current literature of the expression of pain. RIPS scale is the Riley Infant Pain Scale, and it assesses pain in infants and children aged 0 to 36 months by staff nurses in children's hospitals. Categories include facial, body movement, sleep, verbal, vocal consolability, and response to movement or touch. So this is the FLACC Behavioral Pain Assessment Scale. There's 5 categories: the face, legs, activity, cry, and consolability. Each is scored from 0 to 2, resulting in a total score between 0 and 10. So for each of the 5 categories, the 0 is no pain, so what they would be expressing or what the child would look like, whereas the 2 is the most pain. So having a score 10 out of 10 would mean that the child was in pain. It was implemented into emergency departments in a study by Ramira, Instone, and Clark. The goal of the study was to improve pain documentation, decrease time to administer pain meds, and determine the effect of the intervention. With the pain documentation, it went from 17 to 93%, as well as the time to administer pain meds was decreased from 88 minutes to 29 minutes.
Yeah. Go ahead. Hi, come on in.
Hi there, how are you?
Good, how are you?
Good. I'm Emily, I'm the student nurse, and this is the first home visit that I'm doing for the day.
Awesome.
So how are you and Estelle?
We're doing well.
Perfect. So I am here today to give her vaccinations. Did you have any concerns?
I'm just a little bit worried that it's going to hurt her.
Okay, fair enough. Well, what I'll do is I'll go through a pain scale with you so that we can talk about that further. But I'm just going to wash my hands for now, and I'll be right back, okay?
Okay, thanks.
Perfect. Okay. So the pain scale that I have here is called the FLACC Behavioral Pain Assessment Scale. And right now she would appear to be a 0, which indicates that she's not in pain. So she doesn't have a particular expression or smile. She's in a normal position and she's relaxed. She's lying quietly and she's moving easily. She's not crying and she seems content. After the vaccination though, or during, she might move up to a rating of 1 out of 2, which is still a manageable pain rating. So we might see her occasionally grimace or frown. She might appear uneasy or restless. She might moan or whimper. But what we can do for her is reassure her by occasional touching, hugging. We can talk to her and distract her.
Okay.
Okay?
That sounds really good.
All right, perfect. So those will be our management strategies. But I doubt that she'll go up to a 2, which would not be a very manageable amount of pain for her to endure.
Okay.
Okay?
Awesome, thank you.
All right, perfect. Well, I guess we'll do our vaccinations and we'll just see how it goes.
Sounds good.
Okay.
Again, we're not actually going to vaccinate her.
In terms of self-report measures of pain, there are 2 report measures that nurses can easily administer to children. Both are cartoon faces. The level of emotional pain are described to the children, and then they are to indicate a number to the nurse. So on the Wong-Baker faces, you can see that it ranges from 0 to 5, so 0 being no hurt, 5 being hurts worst. And below that, you can see some alternative coding that matches the face's pain scale. And the Wong-Baker face has been critiqued for the smiling face at 0 and the tears at 10 not being accurate to what the child may actually feel. They may see that if they're not currently crying, they may not report a 5 because they don't have tears, even though they may be in severe pain that would be a 5 or a 10 on the face's pain scale. So many nurses will use the face's pain scale now. in which the validity of that has been tested through a few studies, all showing strong positive correlations with the visual analog scale and the colored analog scale, and that most children in all age groups, including the youngest, are able to use the FACES pain scale in a manner consistent with other measures, such as the Wong-Baker FACES. And that for the assessment with the FACES pain scale, children can be 4 or 5 and articulate their pain using that scale. The Wong-Baker FACES, children can be from 3 to 18. It's important, though, to note that children using pain scales can tend to choose only the extreme ends of the scale. So it's important for the nurse to, articulate well what each face means to the child. And by the age of 7 to 8, children are able to use pain scales that adults use, and again, that'll depend on their language ability and ability to articulate their emotions. But both these scales are quite useful. They're quick. They only require the sheet and an explanation from the nurse and don't require that much time. An important concept to keep in mind when dealing with any client is to try and utilize the concepts of relational inquiry, especially during pain assessment. So utilizing the 5 C's of relational inquiry can help nurses perform pain assessments. So the first aspect, or first C, being curiosity. So the nurses should be interested, inquisitive, and open to uncertainty, especially if they are unsure of something upon inspection, such as finding a large mass or palpation, or maybe they see a child who's grimacing and that, maybe that elects them to do a pain assessment. So nurses should always be curious, especially about abnormal child behavior. Maybe the child's not responding, or they're looking kind of slouched over, depressed. So nurses should always be curious. The second one there is being compassionate. So compassion has been shown to reduce pain and lower anxiety, which are both important for children. And compassion requires motivation, sensitivity, sympathy, non-judgment, empathy, and distress tolerance. So compassion is a big component, especially when working with children. The third C is commitment. So nurses must commit themselves to their clients to provide optimal care. Competence. The nurses must possess this ability to integrate knowledge and skill into practice. So knowing which pain assessments are required for different types of clients and when to do them. And the last C being correspondence. The nurse relates to the client in a way that is meaningful to them and requires paying attention to meaning, concerns, and life situations. So the nurse might have to correspond with the parents of a child and ask about their behavior, if it's normal or abnormal. So as well as like another C would be keeping communication open, especially among the departments as well as with the child and the family. Continuing on the idea of using relational inquiry in pain assessment brings us to the 5 W's of relating, which determine how you will relate. So again, no matter what's going on, a nurse is always relating in one way or another, and this just provides us kind of a guideline on how to relate, especially when doing pain assessments with children. So who you are relating to is important. Are you doing an assessment on a child, an infant, or maybe an adolescent? So using the appropriate language as well as tone of voice is an aspect here to keep in mind when doing a pain assessment with a child. So that's important. The next is what. So what are you focusing your attention to? What are you valuing? What are you prioritizing? So it's important for nurses to be aware of body language, using their critical thinking to conduct a thorough assessment. So understanding what the task is at hand is important. When is this third W, and that refers to when are you relating. So in the pain assessment, the nurse must relate to the child in the present. So showing apathy, talking to them, and making them feel comfortable is important during pain assessments. The fourth Y refers to why are you relating. So what purpose or goals are directing you. So in the pain assessments, to understand why you are performing the pain assessment and why the child may be experiencing pain. So asking these questions may guide what assessment you do, where you're looking, or maybe where you're focusing your attention to. The fifth W is where. So where are you relating? So this is important, more in terms of the child themselves, as the context can shape practice. So if you are in the ER and it's quite hectic and the child's small, they may get anxious, they may be scared, which overall will influence the information you obtain, which will obviously influence the care that you provide. So being cognizant of where you are, where the assessment's being done, will enable the nurse to make the appropriate adjustments. So some other important concepts to keep in mind during a pain assessment includes the concept of active listening and observations, so active observation. So it's important for the nurse to always be attentive to the child's during pain assessment and between pain assessments. So noticing if the child's facial grimacing, if it's an infant, are they clenching their fists, are their mouth square when they're crying, are their eyebrows drawn in, can indicate how much pain they're in, or if they are in pain, or if they're just crying. And for an older child who can talk, does their tone of voice or facial expressions match their body language and behavior? So these are all little cues that the nurse can use to, determine if the person's in pain or the degree of pain, or maybe if a pain assessment is necessary. Or even during a pain assessment, if they're reporting a 2 and they seem to look like a 10, then that might be noted in their chart. Another concept is mindfulness. So the 3 P's of pause, present, and proceed. So during pain assessments, the child may be screaming, they may be in pain, and sometimes these pain assessments may be quite hectic. So before a nurse performs one, it might be wise to just pause for a moment, take a deep breath, refocus, center in, and understand what the task is at hand. And then while you're performing your assessment, being present, being aware of what's going on. If you're living in the moment and you switch from doing into being, you'll gather more relevant information. You'll be aware of those subtle cues and aware of how different components may be influencing the child's pain, such as if you're in a busy ER, or maybe it's really cold or really hot, or maybe there's something scaring the child in the room. And the final concept is mindful self-care. So this relates more to the nurse themselves. So in order for nurses to successfully do their job, such as pain assessments, it's important that they take care of themselves. So, pain assessments can require patience, and they need to be focused and attentive and aware. So making sure that the nurse is hydrated, that they're eating, taking breaks, using the washroom. These are things that we really don't want to rush and can really influence care. So it's important that there's nothing that's influencing the nurse's standard of care that can be fixed by just taking care of themselves.
Nursing in pediatrics, considerations. So when working with children as a nurse, there are certain things that are crucial to remember to help the process be less traumatic to the family and the child, as well as make the process easier and less stressful. So when working with children as a nurse, it is important to speak to the child directly, engage the family to earn their trust so that the child can in turn begin to trust the nurse, build a trusting relationship with the child by conveying empathy and using validation, physically get down to their level when speaking with the child, smile, be inviting and happy, and understand the client's culture to build a relationship and break down any cultural barriers. Using a language that the child is familiar with and understands is crucial when working with young children, and also giving time for them to understand as well as ask questions. As a nurse, you are more likely to be in a strong position of support to the child and their family if you are approachable and actively listen to their concerns as well as their questions. Also, as a pediatric nurse, it is crucial to advocate for your patient as the child is seen as having a little voice of their own. Being admitted to the hospital can be a traumatic experience for children and family. Therefore, nurses who will act with friendliness, kindness, and be caring and helpful will help decrease the anxiety and fear. Nurses who smile and are approachable and who are able to talk and actively listen to the children, giving reassuring expert explanations prior to any procedure, will be in a stronger position to support the families and the child through the procedures of hospital admission.